Continuamos con la doctora Linda, va a estar de manera presencial. Continuamos con la charla Formación de talento humano para el Hospital Hub. La doctora Linda DeCherrie es la vicepresidenta de Estrategia Clínica e Implementación en el Dispatch Health, profesora de Geriatría y Medicina Paliativa en la Escuela de Medicina del Mount Sinai. Bienvenida, doctora.
Thank you so much for having me again to speak this time on education. I'm going to focus on physician education. So really the next generation of how we're going to disseminate this model. There's probably as equal important lecture for how we do nurses, paramedics, or others. But in 20 minutes, I'm going to focus on one topic, which is physician education. Again, I'm Linda DeCherrie. I'm a geriatrician, and I work at Dispatch Health, and I'm also a professor at Mount Sinai School of Medicine. And my true love is the education, so I was really pleased to be asked to speak on this. My only disclosure is that I'm an employee of Dispatch Health. So I'm going to start by asking everyone here, I don't know what disciplines you are, but in your training, before you went out in practice, how many of you went on a home visit to a patient's home during your training? I see one hand, two hands, three. Okay, a couple over here. Oh, great. All right, so people are raising their hands. Okay, excellent. That's maybe like a quarter of the room here. Maybe the translation's a little slower, so you may not have heard that. In the United States, this is not common. First of all, there's not a lot of providers of home visits in the United States to start off with. But then even in the programs where they're out there, they don't have a lot of students going with them or residents going with them on home visits. So there is very little training on this. There's a couple of disciplines. So family medicine and geriatrics do require some home visits during their training. And there's a requirement to learn about the healthcare system. That's required. And often that's done as a lecture. So there's a lecture. You can send your patients home afterwards with home health. You can send your patients to a nursing home afterwards, but actually to go there, very few. There was a survey where in 2014, which was very surprising, where there they said that 60% of residents had had one experience sometime in their training. Usually one home visit. So hospital at home. So there is even less of this. There are a few programs, and this is very much word of mouth right now. I think we need to go out right now and do more surveys on this to understand the current state. We know in the United States there's about 250 programs, hospitals that are doing hospital at home that are associated with the Medicare waiver. And there's probably another 50 or maybe 100 that are doing it with a different payment mechanism. So maybe 350 at the most hospitals. And so what we'd like to understand is how many of them actually take their trainees, students and residents, to learn about hospital at home. We know that there is one program that's doing a general medicine fellowship at the Mayo Clinic, and they do a fair amount with the hospital at home program. We know that at Harvard, David Levine has a program from Ariadne Labs, which is an international fellowship on hospital at home. I know there's some challenges this year with the United States and visas, so I'm not so sure how international it will be right now. But then it's not only those students. There are practicing hospitalists, practicing internists now who are being asked to flip from brick and mortar to working now in hospital at home. How do we educate them? So that's the problem we're at right now. And it's very much each program's doing a little bit on their own. And I think in the United States, we need to start collating that and making like some national curriculum to be able to have the workforce ready as these programs start to grow. I did find really only one major article out there that was a review article, and they found 23 papers that had something to do with education between 2013 and 2022. They also did a Google search at that time and found some guidelines in Australia, Scotland, Spain, and the United States. And they put a lot of that together in this article. And really, there's very little that's standardized, but they did highlight a program in Barcelona, a master's course. So what do medical trainees need to learn? And so this is really my experience here and putting some of the literature together. I think the first thing is what I talked about in my first presentation is how do you identify the right patient for these programs? That is a skill set. You need to lead with yes. Don't start with, oh no, not that one, not that one, not that one. How do you like think about, okay, yes, okay, well, fine, maybe not that one, but all the rest, yes. And so how do you teach that? How do you work with them? And that needs to be disseminated very widely, because that is almost every internal medicine doctor out there who works in a hospital needs to learn that, because that is, if we get to really big scale, every doctor would be saying, no, this patient can come right to the home hospital. They don't need to come in the building. The second thing is to work with a multidisciplinary team virtually. So already we have one hurdle, because I don't think we have enough training, at least in the United States, to work in a multidisciplinary team. But now you got to work with that team potentially virtually, because you have nurses and paramedics going to the home. Your physical therapist is going to the home. Maybe your pharmacist is in one building, and maybe you're working from home as the physician. It's possible. And so how do you learn to bring that team together effectively and allow everyone to bring their important skill sets to caring for the patient? One way that we've done that is encouraging the rounds to really be led by the nurse instead of, at least in the United States, often rounds are led by the physician. And so how do you like switch that and really start with the care plan and then having other disciplines add in better? The next thing is how to do virtual visits. Most of the hospital at home for physicians in the United States, the physician is virtual for almost all of the visits. And we'll talk about the couple exceptions there. So they have to learn that skill. And you would say, great, everyone's learned that skill in the pandemic. Everyone can do a video visit. Yes, but sometimes not the hospitalists. If you work in a clinic, I think everyone truly has done video visits now post-pandemic. But if you worked in the hospital, you probably didn't do a lot of video visits. So you have to learn that skill. And you have to learn how to do a virtual exam on a patient who's acutely ill, maybe tethered to a nurse at the same time on video or a paramedic in the home who is facilitating that exam for you. And you have to feel confident about it. So you can observe the patient, very important. You can have reported vital signs to you, also important. But when you need to trust the lung exam of another person or the heart exam of another person in your assessment, and use then also other pieces of information to make your assessment and plan. And for acutely ill patients, sometimes that is difficult to teach some of the physicians. Then I also believe it is really important that you, as a physician, also do the home visits. Learn that skill of doing the home visit. Even if you do 90% as video, you should have to be able to, A, do it sometimes, B, teach someone else who's going to be going into the home on your behalf. And you need to know that. And it's not an innate skill. You need to know when you come into the home that that is their home, right? I'm talking to an audience who all understands this, but sometimes when I do, people don't understand that. You go into their brick and mortar hospital bed, you go in and you turn right away off the TV so you can talk to them. In the home, never turn off the TV because you'll never get it back on, right? So like you need to, it's their home. Where can I sit? You know, some people don't want you to wear shoes in the home. So you got to make sure you have your booties, and how do you wash your hands? Those are all skills that an audience like this knows, but not the typical hospitalist internist. And they need to learn that so they can do it independently and take care of their patients. They know how to do the exam, but how do you do all the other parts of that home visit? And then there's one other aspect, and I've been calling this, how do you practice differently? So if you've been in the brick and mortar hospital 5 years, you know how to take care of patients. You know what antibiotics to prescribe. You know what to do in the EHR, and you feel very confident, but it's slightly different. And a lot of that is, let's try again. You have to think about logistics. And that is a different skill because you just order the meds. Okay, I need to order something that's a twice-a-day antibiotic. Done. And you don't think about it. Okay, so now the EHR might say 9 and 9. And the pharmacist may adjust that because they came into the emergency room. But let's just say it's 9 and 9. May not be the ideal times to do that at home at 9 and 9, because maybe the patient goes to bed at 8 o'clock. So, you know, could you make it for the next day at 8 and 8, and the day after that 7 and 7? And that might be the right way to do it. So you and your pharmacist have to retime those meds to work with the patient. The other thing you have to think about is anticipatory meds. Okay, so this patient has heart failure. Maybe I should have an extra couple doses of Lasix or furosemide in the home so that when the nurse goes and suddenly their weight is up or down, or some doses of potassium so that when I do the point of care lab, I know I don't have to then still send it from the pharmacy to the home. And those meds are often not that expensive. So you have to also learn the cost of things, but to have that anticipatory meds in the home. Again, not something you think about in the main hospital. Another example is insulin vials and pens. So in the United States, most often the vials and pens are cheaper, and that's what brick and mortar hospitals have. The nurses draw them up, right? It's not a problem. They give them to the patients. But in the home, that's not always the right thing. So if the patient is newly, they're on steroids, newly needing to have some insulin, they've never used it before. So then you might have to send a nurse to the home like 4 times a day. That costs a lot of money to send the nurse that often to give them the insulin. But why not send them with pens? Yes, the pen is a little more expensive than the insulin and the vials, but a lot less than sending a nurse, right? And that's much easier to teach the patient to give themselves. And so that's the kind of stuff that has to be thought about. Point of care labs and again, in the United States, most of the time you don't use a lot of point of care labs on the inpatient units, maybe in the emergency, but not always in the inpatient units. And so learning to use that, because when the nurse is in the home and they get the potassium and they give you the weight, you want to right then and there be able to decide what, furosemide and potassium you need to give the patient. And that is something else to think about. But you also need to know what's not possible on point of care. And the other is using extended duration antibiotics or other infusions, because in the inpatient, it's easy to give 4 times a day antibiotic, for cellulitis. Okay, you just order it. The nurse is there, they can do it. But again, sending someone 4 times a day to the home is a lot. So how can we do that differently? And so we use a lot of of elastomeric balls. I saw some out there, or the pumps. This is becoming easier now that many brick and mortar hospitals are also doing 24-hour infusions. The mindset isn't so hard to switch to something so different. But a couple years ago, it was harder when that was really not as prevalent. So these are just, 4 or 5 examples of like thinking very differently, and how we train physicians to do that is really important, because we don't want them to be frustrated. Oh, I can't do everything I would do in the brick and mortar, and then not want to refer more patients into this. So how do we actually train physicians in this? I advocate for simulations. Really need to do simulations. It can be in a simulation center, but it doesn't have to be. We do a lot of, when we start a new program, we actually rent an Airbnb, put a fake patient in the home. We send the x-ray tech, we send this, and then we also have the physician doing their training. And that I think is really good. You can do it in other ways, interactive workshops, doing feedback and reflection, and having a partner work with you and like you give each other feedback is great. Case-based discussions, doing polls. Of course, you can do some online modules to teach some of these things. And then I would also advocate for building some things as default into your EHR, so that you don't have to always remember and think these things. So in the hospital at home order set, the default should be point of care labs and continuous infusion and insulin pens. And then they have to unclick and do something more to get the other options. So those are some of the ways I think are really important as we think about how to actually do this care for our patients. And that's the end of my presentation. So thank you.
Muchas gracias a la doctora Linda por compartirnos las oportunidades y desafíos que hoy tenemos con el talento humano a nivel domiciliario.